Thanks very much for the invitation and the chance to come and talk today. I'm Bryn from University College London, a one-time social worker, but these days a full-time researcher. I'm going to try and give a brief overview of where we are with the evidence for models of care and support to meet people's social needs in mental health contexts, and maybe open up a discussion about where we could and should be going next with this. One thing I'm not going to talk about today is how social workers in particular, or social care staff, meet sort of statutory duties to assess needs, things like care act assessments or how to organise and coordinate care. But I'm going to talk more about what models of care and support have an evidence base and might be helpful once we identify that there's a need to meet. And the kind of areas of life we're talking about in the work I'm going to show you, we talked about these 8 areas of life, helping people with money and debts, housing, work, crime victimisation, social relationships, participation in society, and so on. The stuff of life, really. And I will use terms like social needs, social interventions, social outcomes, models of care and support a bit interchangeably. But this is the stuff I'm talking about, how to help people with mental health difficulties in these big areas of life. And I guess in a social care context, most of us would be comfortable and used to, we don't even think about needing to justify doing that, really, but would there be a sort of rights or a values-based way that, of course, it's self-evidently helpful to help people lead fulfilling and meaningful lives in these areas of life and to meet basic needs. But I guess it is worth just being aware, isn't it, that when commissioners are looking for what to fund, they're often looking at what's in clinical guidance, which would depend on what's got an evidence base for effectiveness. Or when research funders are looking for what they're going to fund, they might want to see something that is going to lead to mental health benefits and effectiveness, and that can be quite narrowly defined as clinical benefits and improvements in mental health symptoms or relapse and so on. We might not be comfortable with that, but I think it's good to know when that's what people are thinking and meaning, and where we might need to tailor the way we present the case for more funding or research opportunities for social interventions and social care interventions accordingly. The good news is that it's often quite easier to make a case that providing good social care and support will have health benefits as well as direct benefits for people's social outcomes. We've known for 50 years and more now about social factors being really important in determining both risk of onset of mental health problems and recovery afterwards. Brown and Harris did pioneering work in the 70s looking at risk factors for depression in mothers. It was mums with depression in particular, and they came up with a whole host of kind of social factors about sort of, both about poverty and about having sustaining, confiding relationships. More recently, my UCL colleague Michael Marmot is a good example of someone doing great public health work, just showing basically wherever you look at mental health, there are socioeconomic gradients. If you're coming from a deprived community, your chances, your risks of mental health outcomes being poorer or worse in so many ways. It comes up again and again. When we think about the kind of clinical treatments provided within mental health services, where they have a social element and recognize that people are part of family units and part of communities rather than atomized individuals who just exist in isolation in the clinic, those types of care and support tend to work really well. If we think about primary care and NHS talking therapies, IAPT, primary care counselling, interpersonal therapy has the best improvement rates. People are asked to list their social networks and types of social support and think about what they're getting from the people in their network. Gaps people still have left and how those might be met. Likewise, when we think about serious mental health problems, people with psychosis, family interventions are just about the sort of best established psychological approach really to help people with psychosis in terms of psychological interventions. And then if we move on to thinking about helping people more directly with social needs, so things like needing a job or needing housing, and actually where we have effective models of support for that, they tend to show health benefits as well. So IPS employment support also reduces inpatient bed use. Housing First housing support improves quality of life. So this is the good news, really, that it's quite often we can make a case that social interventions, social models of care and support are important, not just in their own right and for what they do directly for people's social needs, but that they also have health benefits. And I think that's really exciting for everyone, people in the medical model too, really, that in mental health care has been stuck in many ways for a long time. We have medications that work up to a point, for some people, well, a bit for most people, but they don't work fully for everyone. We have psychological interventions. Not everyone can tolerate them. There's a gap in supply because psychologists are few on the ground. So what else are we going to offer people? If we can provide effective ways to help with all these social domains of life, we've got masses more to target and lots more to offer than in the offer. And that's where social care comes in, really, isn't that? And it is the case that we can pitch to a wide audience. Okay, so I'm going to talk really briefly now about a couple of bits of work that we did in the Policy Research Unit in Mental Health. So this is a unit that's funded through National Institute for Health and Care Research, really to provide direct research capacity for the Department of Health and Social Care to try and meet needs they want. And they asked us to do a couple of pieces of work about what could be offered beyond clinical mental health care to improve outcomes for people with mental health problems, designed to feed into various government strategies, some of which survived the chaos of the last government, others didn't, but hopefully the work is still there to feed into future care and support. So the first bit of work I'm going to talk about is a systematic review where we try to look at what models of care and support to help with these life domains have a really strong evidence base in helping people with mental health problems. And we look for models of care and support that are supported by randomized controlled trial evidence, the sort of gold standard that gets into clinical guidelines and is top of the hierarchy of evidence. So we did a systematic review. It's a few years old now, but at the point we were trying to look systematically for all the evidence there is and found 102 trials that focused on interventions directly looking at these 8 outcomes and areas of life that I talked about. 102 trials sounds like a lot. There's well over 500 trials of antidepressant medication, for instance. So when we're thinking about this is the whole stuff of life, 100 trials maybe isn't that much, but it should give us some sense of what's been tested and what has good evidence for it. This is a published review. We'll share these slides and the links if you'd like to have a look. But I guess the headlines from this really was that from all this research and the really broad look that we had for evidence, there were only 2 models of support really that you could absolutely hang your hat on and say these have really robust randomized controlled trial evidence that they help people. And the first one is the IPS model of employment support for helping people find work who want paid work. And the second one is Housing First, which is the sort of model of giving people direct financial and practical support to maintain individual tenancies for homeless people with mental health problems. So 2 things there that have got a really solid evidence base. But in other of the life domains, so things like social isolation and loneliness, supporting people with money and debt, crime victimization, for people with serious mental health problems, there's a lack of robust evidence about what works and what can be shown to be effective. So despite so much going on in practice, there's a lot where research evidence hasn't caught up. Having done that review, which I think was useful, but didn't establish as much as we might have liked it to do, we then went on to look more widely about, well, what has made it into the kind of research evidence in terms of models of care and support to help people with social needs in these 8 life domains we'd looked at. And so we looked for non-trial evaluations, but also descriptions of models that have made it into the academic literature. We also did a call for evidence around providers to show us things beyond the academic literature. From that, we identified 92 models of support, so different things used to help people with work, housing, crime victimization, or social relationships, and so on. Again, there's 8 domains I looked at. And what we found when we looked at this really was when you look at these models, there'll be a number of things that have some similarities, but are called different things, or maybe have nuanced differences and have been used differently in different contexts. It gets quite hard to see the wood for the trees to try and work out if this looks promising. What is it that's promising? Is it the same as this thing over here, which had less good results, or what's the crucial differences? But to try and sort of help with that and organize how we might think about types of care with people's social needs, we looked at these models of support and tried to categorize them and see if we could distinguish broad different sources of support, so different provider groups and types of support that were being offered could be used to group and categorize these models of support that we'd found. And here's what we came up with. We basically came up with 5 different provider sources of support and 5 different types of support. And rather than spend too much time on this slide, I'm going to go on to the next one and just show you how you can use this. So this was 4 examples of models of care and support We've plotted them with our sources and types of support. Mental health breathing space is this great scheme that gives people a statutory right not to be hounded by creditors for up to 3 months after you've been an inpatient in hospital. So it's a bit of breathing space to get back on your feet before your debts are mounting up and you're getting that kind of stress. So that's a kind of bit of structural help. It's a legal entitlement. You also get access to money advice experts to help as well. Volunteer befriending program is an example of something different where that's not provided by care providers, but it's by volunteer befrienders, really. So that's societal support and it's citizens or community providing it. And I guess this is just an example of how you can try to categorize social care and support into these broad types, which we hope might be helpful in terms of being able to group similar things and say, here's what we do know, and here are types of support that haven't been tried yet. Why not? Or this seems to work better than that, and so on. So it's just a way to try and organize really slew of literature out there. So I just wanted to finish up today by saying if that's a sort of example of where we've got that there's lots of good stuff going on that looks promising and interesting, but very little we could say definitively, we know that this is an effective intervention which helps with this social outcome. Is this a problem? Or is this just where we are with social care, that it is a complex, difficult thing that doesn't lend itself to trials, or trials are unethical in a kind of social care context? And I know there's a range of views on this. One paper I'd really point you towards is worth a read if you have a few minutes. Is this paper, which is now 25 years old, so it's a little bit old, by Anne Oakley, which is thinking about the use of randomized controlled trials in social science settings. Again, I've got the URL here at the bottom. And she makes the point that if we think that randomized controlled trials is a helpful research paradigm, that's just not true at all. That they started off in farming and then they moved to education and have been used in a variety of non-health settings and in all sorts of things where it might be difficult to randomize and to try really. Oakley makes the point that just because something's a social intervention rather than a pill or a physical intervention, it still has a possibility to do harm. And it certainly is the case that it has the possibility to be more or less effective than other types of care. And employment support is a good example of that 30, 40 years ago, the main model was to train and then place. We know from the trials of IPS that actually place and then support people, trying to help people find paid work right away and support them to keep it, is a more effective way than a train and place scheme. And that's now the main model that is used. I think, and Oakley makes a fine point here, just that just because something is a social intervention doesn't get rid of the need to try and establish what are the best ways of helping people, what's the best way to spend limited public money, or what's the best we can offer people. And if we don't have an evidence base, how can we tell that really? So I'm just going to finish up here and hopefully we'll have a bit of time for discussion. Despite the acknowledged importance of social interventions and social care, the evidence base is pretty thin in many areas. There's plenty of work to do for those of us interested in research in this area. There surely are challenges to evaluating social interventions, which are complex and are often designed within a local context. You don't want to standardize it completely. But I don't think these are insurmountable, and I don't think they're necessarily more complicated than in many other areas either. And we're hoping that the work we've done gives us some sort of benchmark of where we are at the moment, and that this conceptual framework might be a helpful way to categorize programs going forward and help evaluation. I want to leave you with a question: is evidence-based social care something you'd welcome and something we think is possible? You can probably tell where I'm coming from, that I think is a long-term goal, that it could and should be really, and that there's no reason why we couldn't evaluate things and know what are the most effective types of care and support we should be offering. I think when we go and see our GP, we're offered some new medication or some surgery, we'd want to know that that's been tested and shown to be effective, isn't it? Why should that not be a goal for social care as well? Great to hear what everybody thinks about that and how you think the next steps are to achieving that. Okay, I'm going to stop there. Thanks very much for your time.